verse from the Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
صدق الله العظيم. الدكتور محمد حمدان رئيس اللجنة المنظمة للمؤتمر، الدكتور محمد سليمان رئيس اللجنة العلمية للمؤتمر، الأطباء الزائرون من مستشفى جامعة كولومبيا الأمريكية، ضيوفنا الأعزاء من داخل وخارج الدولة، السيدات والسادة، السلام عليكم ورحمة الله وبركاته. نرحب بكم ونشكر حضوركم الكريم للمؤتمر الدولي لطب الأطفال الذي يقام للمرة الرابعة على التوالي بتنظيم مركز كيدز هارت الطبي بالتعاون مع مستشفى جامعة كولومبيا ومستشفى نيويورك بريسبيتيريان.
In the name of God, the most merciful, the most gracious. Dr. Muhammad Hamdan, Chairman of the conference. Dr. Muhammad Sulaiman, Chairman of the Scientific Committee. Dear guests from Columbia University Medical Center and New York Presbyterian Hospital. Dear guest speakers, ladies and gentlemen, good morning. Allow me to welcome you all and thank you for your attendance to the 4th International Pediatric Conference, which is organized by Kids Heart Medical Center in collaboration with Columbia University Medical Center and New York Presbyterian Hospital.
على مدار الأيام القادمة سيقوم أطباء من مركز كيدز هارت الطبي ومستشفى جامعة كولومبيا باستعراض خبراتهم الطبية من خلال مجموعة من المحاضرات وورش العمل التي تناقش أحدث ما توصلوا إليه في تخصصات طب الأطفال. المؤتمر سيلقي الضوء كذلك على دور مركز كيدز هارت الطبي الرائد بفروعه الثلاثة في أبو ظبي ودبي والعين في تخصصات طب الأطفال في دولة الإمارات العربية المتحدة التي لطالما كانت سباقة في شتى المجالات وخاصة في مجال الرعاية الطبية.
During the coming 2 days, Kids Heart Medical Center doctors will showcase their medical knowledge along with Columbia and Cornell University doctors through lectures and workshops which will discuss the latest technologies in pediatrics. The conference will highlight the role of Kids Heart Medical Center in its 3 branches, Abu Dhabi, Dubai, and LA, specializing in pediatrics in the United Arab Emirates, which has been the pioneer in all fields of pediatric care.
نحن في كيدز هارت بفروعه الثلاثة نفخر دائما بتعاوننا مع زملائنا في جامعة كولومبيا الطبية التي تعد واحدة من أقدم وأعرق الجامعات في أمريكا، إضافة إلى زملائنا من كافة المستشفيات والجامعات الأخرى. نرحب بالحضور الكريم مرة أخرى ونتمنى لكم طيب الإقامة في العاصمة أبو ظبي.
We, Kids Heart, are proud to cooperate with our colleagues at Columbia University Medical Center, which is considered as one of the oldest and most prestigious universities in America, in addition to our colleagues from other hospitals and universities. We welcome you all and wish you a pleasant stay in Abu Dhabi.
Please allow me now to welcome Dr. Muhammad Hamdan, Chairman of the Organizing Committee.
Good morning and Assalamu alaikum, ladies and gentlemen. thank you for my kids and sister. It's a family business, so that's why you hear name a lot. You hear my name a lot. So thank you all. Nice introduction. So allow me to welcome you on the behalf of the scientific committee, my colleague, Dr. Mohammed Suleiman, who you don't see often because he's energetic, he's basically working on 1,000 horsepower. And on behalf of our colleagues and physicians in Kids Heart Medical Center, Dr. Wasfi, our pediatric endocrinologist, Dr. Dina Saleh, who's a pediatric neurologist, Dr. Hamdi Siouf, and Dr. Muhammad Taher. So this is probably the only center that I know in the region, and definitely in the UAE, which is established, operated, and managed by physicians only. So thanks God, no offense, we don't have business or corporates running us. So the idea of having Kids Heart Medical Center is to specialize in pediatrics and all its specialties. Our experience started in Dubai in 2013, and then moved to Al Ain the year after, and then this year we just opened our third branch in Abu Dhabi. And we wanted to welcome you all to the conference. One of our missions that we share with our colleagues in New York Presbyterian Hospital and Columbia University Medical Center, which I would like to ask to thank our colleagues that they flew all the way from the US to come here, is to market your services and your quality of services through education. We're the only conference in the region, and definitely in the UAE, that is done with free registration and commercial free. That's why you don't see any pharmaceutical companies being shown around. And we're proud to have this large number because we share your values of education, and we share the values to have access, care, and feasibility for everybody. Our logo in our centers is actually anybody who comes into the center doesn't get out without being treated, regardless the gender, regardless the language, regardless where they are from, regardless whether they have insurance or not. And we can afford to do that because we own our practices. It's different when you have a practice that is owned by physicians and managed by physicians, because only reason why we went to medical school and to went to residencies and fellowships is to be able to serve our children. And we're proud to be able to do that in the UAE. And I thank you all for your support. And I'd like you to enjoy the conference, enjoy the lectures, and then enjoy your interaction with each other. And I hope that this conference will be successful, similar to the previous conferences. And it's only because of you we have this success. So thank you again, and we'll be seeing you more frequent over the coming 2 days.
Please welcome Mr. Burak Mulatiali, Vice President for Global Business Development, New York Presbyterian Hospital.
Good morning, ladies and gentlemen. On behalf of New York Presbyterian, I would like to welcome you to fourth annual Kids Heart International Conference. We are honored to be here, and I just want to really thank Kids Heart leadership for putting this amazing conference together. We working with them very closely. We know all the efforts that goes behind arranging this, and I think they really take pride in really connecting latest advancements in pediatrics around the world with what's happening in the UAE. We also have great guests here with us today from Columbia University, from College of Physicians and Surgeons, and you will get to meet with them and hear their presentations as well. So before I let you enjoy the conference, just want to tell you a couple of things about New York Presbyterian. As you may know, New York Presbyterian is one of the most comprehensive and advanced medical centers, academic medical centers in the United States. We take pride in our tripartite mission, cutting-edge research, patient care, and education. And we can only do that thanks to our two Ivy League school partners. That's, again, Columbia University College of Physicians and Surgeons, and Weill Cornell Medicine. So, and Kids Heart, we were able to bring that expertise to the United States, but also our clinicians and doctors were able to really learn from their experiences there as well. And we really look forward to working with Kids Heart going forward. You'll also hear from Dr. Stanberry, and he'll tell a lot more about Columbia University and MIT's capabilities in pediatrics. But what I want to tell you before I let you enjoy the conference is that hopefully we're looking forward to working with KidsHeart in the future years. We're actually continuing to talk about how we can further advance our relationship. And we believe that there's going to be more exciting partnership opportunities that's going to come, and hopefully will help United Arab Emirates, but also our clinicians back home. With that, please enjoy the conference. Thanks for, again, allowing us and hosting us in Abu Dhabi, and look forward to a great 2 days with you.
Allow me to introduce Dr. Lawrence Stanberry, Chief of Pediatrics at Columbia University Medical Center.
Good morning. First, I want to congratulate Dr. Hamdan and Dr. Suleiman on organizing another exceptional conference, so you're really to be congratulated. Second, on behalf of Columbia University and New York Presbyterian Hospital, I want to tell you how much we appreciate this invitation to join you for this conference. Our hospital is an interesting hospital in terms of the kinds of patients we care for. The expertise both at Cornell and Columbia are renowned in the areas of cardiology, oncology, gastroenterology, and it's a hospital that specializes in caring for children who have particularly complex illnesses. There's a measure in the United States referred to as the case mix index. It's a measure of just how sick the children are in a hospital, and our hospital actually has the second highest case mix index of any children's hospital in the United States. Second only to Stanford, so on the East Coast of the United States, we have the highest case mix index. That means at our children's hospital, we literally care for the sickest of the sick. And it's one of those things we take great pride in. And you will hear from some of our colleagues today at Cornell, or from Cornell and Columbia, who work in New York Presbyterian with regard to the kinds of care that we provide. Partnering with KidsHeart has been a real joy for the last almost 5 years now. And it's one that we expect to see continuing for a very long time into the future. They've given us the opportunity, particularly in the area of cardiology, to continue to expand the services that we provide at New York Presbyterian. And most recently, just in the last month, we've opened the new Weinberg Center for Pediatric Infant Care. It's a one-of-a-kind 17-bed unit designed specifically for babies from 0 to 3 months of age to receive cutting-edge cardiac care. And you will also, I believe, be hearing from Dr. Neil Basha, our head of pediatric cardiothoracic surgery, about some of the remarkable work going on at New York Presbyterian and at Columbia. So finally, I just want to tell you how much we are, again, pleased to be here. We're all here for the same reason. We learn from each other. That's very important. We're all here for the same purpose, which is to make a difference in the lives of children. So I want to congratulate you for attending this. I look forward to getting to know you. Thank you.
And now with Mr. Michael Brendan Davis, Chief Operating Officer, NMC Healthcare.
Assalamu alaikum and good morning to everyone. My name is Michael Davis. I'm the Chief Operating Officer of NMC Health. And I'm often asked to speak on behalf of NMC in front of groups, but when I saw the list of the speakers and the topics that you'll be speaking on over the next 3 days, it made me completely lose my train of thought because actually I felt really stupid when I saw some of the things that you were speaking about, because what you guys do is so important. It makes the work that someone like I do seem so insignificant. But first off, thank you to KidsHeart for the invitation to participate. We're very, very proud of our company and the work that we do here in the area of pediatrics, in the field of pediatrics in the UAE. But we're strengthened by our collaboration and relationships with people like the folks at KidsHeart and by association, our friends from New York. It's an honor to be associated with this weekend. I'd like to take the opportunity also to announce that NMC has signed a collaboration agreement with Cincinnati Children's Hospital, and similarly to the relationship that Kids Heart has with Presbyterian of New York, this is not a collaboration agreement in name only. Our idea now is to bring expertise, Western expertise, people that practice evidence-based medicine in subspecialty areas, tertiary care, actually to the UAE to improve the care provided here. I think those of us who have lived and worked in the UAE for some time know that many of these agreements have been agreements on paper alone, but for us it's more important really to have the expertise here within the country. We have such amazing physicians here now that do great work, so we're excited about helping to strengthen that and to continue with these collaborations. For those of you that don't know NMC is the largest private provider of healthcare in the UAE, and we're the 5th largest healthcare company in the world, listed on the London Stock Exchange since 2012, but we are definitely an Abu Dhabi company, a company with Middle Eastern roots. Our founder, Dr. B.R. Shetty, founded the company 44 years ago, and he began seeing patients out of one room in his home with his wife, Dr. C.R. Shetty, who is still the chief medical officer of our company. 44 years ago, Dr. Shetty's thought was, check the patient's pulse, don't check the purse. And we continue that today, and that philosophy of putting the patient first has helped us grow to the company we are today. So again, thank you to the people at Kids Heart. Thank you to Presbyterian for sharing the stage with our Cincinnati folks over the next 3 days. And I'd like to welcome the Cincinnati folks here to the UAE as well. And I wish all of you a very, very successful conference. Thank you so much.
A few words about housekeeping issues by Dr. Mohammed Hamdan.
I know you're sick of me, but I promise this is the last time. So just a few things just for the delegates and audience. Number one, for the evaluations, because it's quite essential to get your CME credits. So if you look at your booklet, they have the evaluation forms inside, and this is something that we just take away from the brochure. Each session has a code that will be given at the end of the session, so you just write down this code. And then at the end of the day, whether you can wait until the workshops, if you're attending the workshops, but if you're not, you can just drop the evaluation form in the boxes that will be designed, and it has to be done today. So only evaluation forms are valid only for 24 hours, which is the same day. And based on that, your CME hours will be calculated. You know, HAD regulations are very strict in this, and this is the only way we can control that you really attended. The second issue is please register for the workshops as early as possible, because all workshops we have 4 today, and we'll announce the locations later, but it's likely going to be these 3 halls plus some 4th hall. Please register during lunch break. That will open registration, because it's first come, first served. And each workshop is limited to a number anywhere between 50 to 100, because some speakers have handouts. So beyond that, just put your phones in silent mode and enjoy the lectures.
And now, let us begin the conference with the first session. I would like to call upon the moderators, Dr. Carrie Starkey and Dr. Maya Prabhakaran.
Good morning. Welcome to the conference. I have the honor, thank you to Dr. Suleiman and Dr. Hamdan for being included in the conference, and I get to introduce your first speaker. So our first speaker is Dr. Mohammed Habib. He is a consultant in neonatology. Since 2008, he has been working as attending neonatal and perinatal medicine doctor in Edmonton, Alberta, Canada. Since August 2016, Dr. Habib is the senior neonatal and perinatal medicine consultant and head of department of the NICU and Newborn Services of Royal Hospital, NMC of Abu Dhabi, UAE. Likewise, he's the chairman of pediatrics at NMC, Royal Hospital of Abu Dhabi, UAE. His degrees: he graduated with an MBBS, I might mess up the abbreviation, from Minsk State Medical Institute in Belarus, and he was also awarded the Jordanian Board in General Pediatrics and awarded Neonatal Perinatal Medicine Fellowship Program Certificate from Canada and LMCC.
It's my great pleasure actually to be here,
and I would like to thank the Dr. Kids Heart, Dr. Sulaiman, Dr. Muhammad. I'm not sure they are out of love that I'll be the first speaker, or that's rubbish, but we'll see. I'll try to go over 3 cases of my really practices, and I hope that the time will help me. So, I do have no conflict of interest to declare, and right away we're going to go to start with this is my just what I did my initial. I'm going to go right away with the first case. And I'm going to actually a little bit throw some questions, but it doesn't mean that the crowd should answer it if there is any answer coming up. So in the first case, the answer we're going to answer, the question we're going to answer, why we are not able to wean this newborn from respiratory support. This is a male newborn, product of unidentified delivery, spontaneous vaginal delivery without any complication, gestational age 37 weeks, with a birth weight 3 kg 264, Apgar 899 at 5 and 2 minutes respectively, who was born to a 30-year-old mom, gravida 3 para 2, PBS unknown, one of the risk factors. She has negative serology, unremarkable course of pregnancy. She has also another risk of a prone rupture membrane for 25 hours, and though she was covered with antibiotic. So in the day 1 of life, there's a very smooth prenatal delivery and post-natal care. There's no need for intervention. He has fairly nice transition. However, at the age of 6 hours, he developed a respiratory stress with tachypnea and grunting, which is a very common things all the pediatrician face, and that actually also associated with desaturation. This is the first X-ray done just after the respiratory stress, and I'm not sure if I can use this. I would like you to illustrate in this on the support of non-invasive CPAP of 30%, you can appreciate that maybe there is a infiltrate on the left upper side. In the right side, you can see maybe increase the epigenicity, more blackness, and that's it. So complete septic workup done as always, and he was maintained on the non-invasive support with the CPAP. Started an antibiotic as always we like, ampicillin, vancomycin. Septic workup actually came and was a blood culture positive with a group B streptococci. So we have some answer here. And the antibiotic therapy was continuing with the drug of choice penicillin G. Now, although the clinical and lab sign of sepsis completely resolved with the treatment, however, the patient couldn't be weaned from the respiratory support. He still needed to be in the CPAP. And in fact, not only this, when we did the X-ray on the 5th or 6th day, and that was the room air, he needed more oxygen data. You can appreciate that on the right side, we see more haziness. We see more kind of a loss of the lung volume. Anybody have any clue what is happening here at this point? Okay. So on day 10 of life, the patient respiratory compromise was unchained, You continue to need a non-invasive support. You require more oxygen, up to 30%. Sorry for the errors, just apply there. And even the X-ray, we see even worse in just X-ray finding. So it's almost completely the right side obliterated, and we are losing the lung volume. Anyone have any idea what is happening here as a spot diagnosis? Louder, please. Okay, there's a pleural effusion. So this is just putting the comparison of the X-ray from the day 1, day 4, and day 10. And you can appreciate the deterioration between the finding, although we treated the sepsis. I mean, we have a group B, we diagnose it, we have blood pressure, and it was treated. However, we can't really yet, we see deterioration in the respiratory and in the radiological findings. So here, what is the diagnosis choice would be here to confirm what we are dealing with? I know it's the first presentation, maybe going to ask the crowd is not the best thing. So I'm going to actually skip a lot of things and answer the question here. So, the lung ultrasound actually. And that case actually more than 10-year age. However, the lung ultrasound is more now than we used in our field. And that ultrasound examination confirmed the diagnosis of right-sided diaphragmatic hernia. So the infant was transferred to the pediatric surgery unit. The hernia was repaired successfully and further recovery was made. So the entity of a delayed onset right-sided diaphragmatic hernia with the group B streptococcus septicemia is there. And there's been reported many cases over the years. There are more than 30 now even. The incidence is very low, frankly saying, because if you look, 1 in 6 million cases happening, but that is very rare, but still happening. And why is that happening? What is starting first? Is it starting first? You have a group B sepsis, which is causing a inflammation of the liver, so it will not really go up to the lung, to the thoracic cavity, or because we are using a pressure, distilled pressure, and that distilled pressure also preventing from the picture of going up. Either way, we can't tell, frankly saying, either because of the hepatic mechanism or because of the interface pressure. And the right-sided diaphragmatic hernia appear to be, all the X-ray will be normal in the first week of life or more. But after the initiation of the treatment and antibiotic treatment, you can start seeing whole picture, the flare-up of the radiological presentation. And always the subsequent X-ray is going to show you the deterioration and the hernia coming to the right side. Of course, if it's recognized, it's like 100% survival without any sequela. And that actually just alarming us that if there's any persistence, if there's any other entity that could cause that you need more support. But one of the things that with the group B, if we still need more respiratory support and we see deterioration in the radiological finding, we should always keep in mind that maybe we dealing with a congenital diaphragmatic hernia on the right side. All the published cases actually, they prove that we have a secondary specification to the right side, and as a neonatologist, pediatrician, we should be aware about the association between group B streptococcal pneumonia, sepsis, and the delayed manifestation of the diaphragmatic hernia. And actually, this is the message should be not only from this case. I'm sorry, I should put this like in front as my objective or at the end. Objective always we should things not always as looks like. So we like to see, okay, this is sepsis, group B, we are treating that. Then always we should have the passion and we need to do more. Okay, now we're going to go to the next case. And this is not an apnea of prematurity. What is the etiology of this apnea? Well, whether you're going to say sepsis, well, we'll see. And this is a 10 days old female newborn, spontaneous vaginal delivery, uneventful transition, gestation registered 4 weeks, but she looks like 32 weeks. Birth weight 2,437 grams, Parker 578, and she was admitted to the intermediate clinic because she was quite stable. She was born to a 26-year-old mom, gravid 3, para 1. Serology are negative. GBS is unknown, but she has a risk that was positive in her previous pregnancy. She has had a history of herpetic lesion, which is not active in this pregnancy, so she has negative history. She went to a spontaneous premature labor, and there is no history of coronary rupture membrane. At the time of the delivery, she received 1 dose of ampicillin. That was a stable newborn, just a feeding well tolerated. As a precaution, started with antibiotic ampicillin, gentamicin, and discontinued 48 hours as usual with a negative culture. Now, in the 5th day of life, she developed cluster of multiple apnea associated with bradycardia and desaturation. And we know 34 weekers, they have 50% chances that they might have apnea with prematurity. She became lethargic with a hypoactivity and poor tolerance, feeding, hyperglycemia. She was admitted to the NICU and a complete septic workup done, including herpes simplex virus with a PCR-6F blood also. And she was started on antibiotic with some non-invasive respiratory support. Her septic workup came to be unremarkable. She did have actually a good clinical progress, and we've been able to win the CPAP and start resuming the feed. However, only in 12 hours, she developed again rapid deterioration with crash course, with a clinical manifestation of a septic shock and DIC. She has a pulmonary hemorrhage, GI hemorrhage, and she was hemodynamically unstable with wide pulse pressure. So she was managed accordingly with respiratory support, mechanical ventilation, IP, surfactant. She was maintained on inotropic support fluid, antibacterial, and antiviral. Of course, as we say in Arabic, لا يشتوى ملك في المدينة, but we have 2 maliks here. So 2 cardiologists. So I'm just showing, as we usually ask the cardiologist consult, and we are, the finding was a large PTA stealing lots of blood from the aorta. That one of the things that the findings. So in day 12, 11, 12, she continued to be critically ill with the generalized edema, hepatomegaly, still tachycardic, hypotensive, and sign and symptom of congestive heart failure with decrease in output. Now blood pressure and CSF came positive and negative. PCR for herpes also negative. Now serum troponin is 0.34, which is almost 10 times the normal range. Nasal and rectal swab for viral study still pending. The hematological screen was still abnormal. Now, what is the investigation of choice and why? Maybe I want to see somebody volunteer to say something here, guys. what you want to do, guys? Oh. But I wanted to show something. Oh, here we go. I just. Of course, we need to do an EKG. We are not good in EKG, the cardiologists are helping us all the time with that. So basically, this is what we found in here, EKG. And I'm going to just go for the most basic, because it's not really. The most basic we see in the lead number, the second lead, in the 4R, and in the chest lead. In all these leads we can see ischemic changes, and that represented as the ST depression segment. And it's just more to show the changes happening in the V6. So the interpretation, I just go to the most simple just about the ischemic changes. Now, in the day 13 of life, she developed a VTAC. And she needs to be resuscitated with all the means, including the shocking her and giving her medication. But she continued to resistant hypertension despite all the inotropic support, even the calcium chloride, as he tried to see if that will help. She has a refractory ventricular tachycardia, not responding to medical treatment, and interactive with congestive heart failure. And the parents actually counseled for poor prognosis and alternative approach. Now the lab called us with the following information. So, what virus is this? It's RNA virus. It is stable in acid pH, resistant to lipid, capsid has 60 copies each of 4 proteins, small protein, and have at least 72 serotype. Anybody can volunteer. Oh, sorry. Come on. Very nice crowd. Thank you, Dr. Sliman, Dr. Muhammad. And here you go. There's another, beautiful but ugly picture for this. Beautiful picture for ugly virus. Any volunteer?
Is enterovirus P72?
Say again?
Enterovirus.
Enterovirus, that's correct. It is just enterovirus. And we like to talk about herpes in the neonatal period, and we really treat herpes aggressively. But this is was enterovirus. And here the swab was positive for enterovirus. The esophageal swab was also positive for enterovirus and was confirmed later to be positive for Coxsackie B type 4. So we did actually with some sepsis, but really we did with the enterovirus myocarditis. And in day 16 of life, with all our treatment available at that time, and actually still the same, it didn't change from more than 16 years. We gave her the immunoglobulin. At that time, the phenylquinone actually was a study drug, and it was unfortunately very disappointing result with the phenylquinone. It was after 11 years of study, we didn't reach anything, and then they stopped the study. But we tried actually. We did it at that time, and we gave it for the baby. And the parents was counseling to transfer her to a heart institute in Edmonton, Alberta, for further management and ECMO. And actually the team came and took care of the baby on a portable ECMO at that time. So, enterovirus infection in neonate, most common cause of viral myocarditis. And it's characterized by acute inflammation of heart and myocyte. Coxsackie B account for at least 50% of the cases we see in that age group. And the percent actually have an effective barrier,
So the transmission doesn't happen merely intrauterine, it happens after that. So most of the infection acquired in the prenatal period from the infected mothers. And that actually associated with more morbidity and mortality. And there is no difference between if you have cesarean or vaginal. It's either way. There's also some history of nursery outbreak. It is a rare disease, and the WHO actually reported the incidence of cardiovascular involvement after intrauterine infection 1 to 4%. Incidents have some seasonal pattern. It's come more in the fall and summer, and it's more happening in male as well as the bad thing happening to males. So the manifestation is heart failure, ischemic EKG, the echo will show us the contractility and dilated ventricles. Of course, elevated cardiac enzyme. PCR, an excellent diagnostic tool to deal with suspected cases because it is sensitive and specific. So we do encourage, if you have any picture, don't hesitate to send for encephalitis. Temperature usually fine, but it will take 1 week. And serology have some issue with a swab and require actually acute and convalescent sampling. And there's a large number of cell type. So management actually, until recently, we don't have really an effective management. So basically, medical care is the aim to minimize the pandemic demand of the blood body, sorry. No specific proven therapy, all supported actually. All that we can try to treat is a congestive heart failure with the medication available. And there's still, it's really a fatal disease. 75% have a high mortality rate. And yet there's a complete recovery of ventricular function up to 50% of the patients. Some patients are going to go for a chronic myocarditis and dilated cardiomyopathy. And who else go to the cardiomyopathy might have need a heart transplant. Usually it presents very classical. It's just a collapse maybe with some of the studies done here in Great Ormond Street between 2001 and 3. They were usually presented after a week of life. They had all the ischemic changes in the EKG, the heart failure, and the cardiac enzyme risk. Treatment, I mean, for the baby, after she reached at noon, she had been placed in an ECMO for a while, and with the of the study drug, but with no actual help. She grew up also later in her blood a multiphilia, and she was withdrawn from support in the day 25 weeks. So enterovirus is a serious life-threatening infection for a neonate. High index of suspicious should be considered in cases with VIC and myocarditis. High mortality rate is associated with viral myocarditis, and more research, of course, need to be done to find a better treatment. Right. This is actually also a long link case, so I'm going to try to go over this case as fast as we can. And I'm going to just try to say this is a case of congenital pneumothorax. In my professional life for the last 30 years, I saw one case of congenital pneumothorax during my fellowship. And it was very interesting. It's still everything I can learn from that case because you can learn a lot. The maternal history and baby, 3 weeks old female newborn, late preterm. She's product of spontaneous vaginal delivery, gestation at 35, birth 3 kilograms, 66 grams, Abgar, unremarkable, and mom 36 years old. Mom actually presented when she came to Berlin with our leg swelling and extension, and the ultrasound shows at 35 weeks a hydrocephalus with the pleural effusion. So mom also has had a history of a stillbirth at 35 weeks ago. I know clear etiology, but I think we can't say that we have clear etiology maybe. So basically, antenatally, baby in the fetal medicine, they did actually the right sided stent inserted and the left sided aspirated. The fetal medicine did that. And mom given dexamethasone because of risk of preterm labor. Baby, right away that we resuscitated, we actually did have a plan as a neonatal team. We have a full plan prepared to have this baby, and the team was prepared to do the chest tube, everything in the delivery room here. So he was intubated right away, resuscitated, intubated, and we discovered a right-sided pneumothorax right away in the delivery room. We also aspirated the left side because we knew that there is a perfusion on the right and left side. So we aspirated that side for 65 cc of serous fluid, and we established a line and transferred the baby to the ICU. Of course, he was maintained in a conventional ventilation, given a surfactant. He was switched to high frequency ventilation due to difficult ventilation, and a both chest tube established on both sides. So this is actually the first X-ray done for him. You can appreciate that we have the pleural effusion on the left side, we have the pneumothorax on the right side, we have the two lines there. Within 1 hour of time, the tube was done, just tube. And this is draining the air from the right side. And this is just a picture showing us that we have the two tube actually. So the left tube was draining the serous fluid, the chyme, and the left tube was the right tube was draining the pneumothorax. And this was almost at second or third day of life. This is third day of life, very stable course with the maximum support. Just a follow-up of, I'm sure not many of the X-ray, but I'm going to come to the management-wise. So we didn't have actually a lot of issues with the baby more than that. We have the chyme, we need to drain the chyme as needed, we need to support with the antibiotic and hemotherapy, and of course the plan for feeding, which is started as a TPA, of course, TPO. So again, this is almost at 10 days of life. We can see still we have to just tube to get some air. And this is more close to the discharge. So I'm going to go very quick here for the management approach. As it's antenatally diagnosed, maybe needed for support, we need mechanical ventilation, we need to eliminate the accumulation of the chyme, we need to control the infection. Nutrition and fluid replacement is the cornerstone in the management of this baby. We use all the IVGs, somatostatin at that time, and our surgeon was involved. And the baby actually had a smooth recovery course, clinical course, and he or she discharged home breastfeeding and special formula. And in a very quick here, Carothorax is there, very rare, but it's still happening. And congenital, most of the cases happening, either also post-surgical cases. When we have the first surgical surgery. Main complications are common hypoplasia and hydrocephalus. As I mentioned, it comes most cases secondary. In some cases, it's associated with syndromic disease. So you should just be aware that it could be actually maternal or nonal or even Down syndrome. Of course, it's more on the right side, but it happened in the males. I'm going to just go for very quick here. That prenatal diagnosis is very important in the management and also prognosis. So this is give us us the chance to plan for the management, plan us for the prepare the parents. Medical therapy, of course, including dural range and total TPN and needle change to glyceride, formula for oral feeding, and all we should remember about Down syndrome. There's different approach for diet reaction, and some, of course, no doubt that starting with TPN with a high protein, low fat, the MCT, and some of the studies showed that the preference of having however, we shouldn't really prolong our medical treatment more than 1 week. Otherwise, we are going to avoid the risk of the infection. Shunting procedure, always we need a shunting procedure to drain. And there is some symptom that can be the thoracoscopic approach, which is also minimize the risk of more aggressive surgery. This is actually a very big study done with Australian Saudi study, but I'm going to skip that. And go just to say about the aim. There's a study comparing the TPN with MCT, and they found that most of the started the TPN much better than MCT per se. And this is a guy, Dr. Pergato, the guy, the late Pergato, I owe for a lot of my research and work. Thank you.
Thank you, Dr. Gandhi, for the perfect talk. And now we have Dr. Peter Dayan, who will be talking to us about two emergency case scenarios in pediatrics. Dr. Peter Dayan is a professor of pediatrics at the Columbia Medical University Center, and he is an associate director for the Division of Pediatric Emergency Medicine. I don't think there will be anyone who is more qualified here to talk about the emergency cases in pediatrics. He has been a director for the Pediatric Emergency Fellowship Program for more than 15 years now, and he has a keen interest in research activities also. So now we welcome Dr. Peter Dayan to give us a few insights to pediatric emergency medicine. Thank you.
Good morning, everybody. So I'm going to talk a little about the challenges and imperatives of sepsis diagnosis and treatment. And this is something that, certainly in New York and something all over the U.S., has become a topic that we have to be looking at every year. We're constantly challenged by missed cases, and we're constantly trying to improve. So here you are. I don't know if you are Where's Waldo fans, but this is a typical look at our emergency department in the middle of Saturday night. It looks like I wrote 42 patients, God knows we're coming up there, but all are 6 to 12 months, all with temperature of 39.8, all have a runny nose. Anyone septic or likely to become septic. And our job is to figure out who that one person is in that room who is going to need our help over the next few hours. It's very challenging. In the U.S., there are 75,000 children hospitalized with severe sepsis annually. $5 billion in healthcare expenditures. Fortunately, in 2016, a consensus group figured out how to make sepsis more accessible to everybody. There were very, very challenging definitions of septic shock and sepsis through the years. And now they've actually tried to redefine it so it's more understandable. And here you have the definition of sepsis. And it's life-threatening organ dysfunction. It's really the key piece. When you actually go down to septic shock, it's a subset of those with life-threatening organ disease who really have profound circulatory, cellular, and metabolic abnormalities. These are the kids who you look at and you know they're in septic shock. They're very, very ill. And the trick is to try to figure out those kids who are in sepsis aren't going to you're going to try to prevent from going into real serious septic shock. So here are my two objectives: are to understand the challenges and includes the identification of kids with sepsis, and to emphasize crucial aspects of the emergent management. And I break them up into two pieces because that's what we're doing these days. We're trying to say, how do we identify them well? And then once we identify them, how do we care for them well? And then kind of follow-up objective is to kind of think through, okay, personally we can identify them and we can care for them, but kind of on an institution level, how do we do that? How do we get who has sepsis? How do we get that to everybody? The second piece is how do we make sure everybody's following a treatment protocol? And the last part of it that I'll get to at the end is kind of how to measure the success of being able to screen and being able to treat. So this is actually, we have up front, so a child comes into our emergency department and the nurse at triage is looking at all the kids. We actually have a physician out front or a nurse practitioner out front too. And they look and say, does this kid screen positive? That big red arrow up there, it says, escort the child immediately to an MD for evaluation. Sometimes we do have a doctor up front, but sometimes they're in the back part of the emergency department. But we created a sepsis trigger tool that says this patient is at risk. Obviously you can't see, I don't know what you can see back there, but there are different pieces to this. We're going to walk through these pieces. Again, this is about identification. So fortunately, the vast majority of children who have sepsis, or are going to go on to septic shock, they're telling you I have a risk factor. So the majority of kids in this study, 90% were at high risk. And these are our high risk criteria. And you really, it's a nice long list. You can come up with your own list. There are just two categories, those who are immunocompromised and those who have indwelling lines and medical devices. So right off the bat, we know when a kid comes in, we think sepsis if we were just trying to think of that, and we see that they have those kind of risk factors. But a lot of kids don't, some of those kids don't have risk factors. The majority don't have risk factors and maybe at less risk for sepsis, but we've got to pick them out too. Obviously, they're going to generally be hypothermic or hyperthermic, and they have a mental status abnormality, have delayed cap refill, weak pulses, mild or cool skin, or fatigue cap. Those are pretty standard, and I hope all of us in this room could look at those kids and say, sick. And then we have that vital sign abnormality. How do you deal with abnormal vital signs? Can vital signs alone pick up those outliers, those strange kids out there in that mass of the waiting room who actually have something you need to deal with very quickly? So here's the case. A 1.5-year-old girl, no past medical history, cough, fever for 24 hours, has a temperature of 40.1 centigrade, a heart rate of 188, respiratory rate of 36, blood pressure, pretty normal. Well appearing, well perfused, no focal findings when examination certain. I guess she's not certain, I'll take that out. Give an antipyretic, see her weight. Give an antipyretic, dip urine negative, influenza test is negative. You would discharge, typical kid with a cold, right? Observe and reevaluate when fever is lower, or complete the further workup. And that's the kind of kid that we're presented with all the time. What do we do with this child? What am I paying attention to? So this is the one that I think drives us a little bit crazy, is the heart rate is 188. Is that normal for fever? Is that normal for the illness? Or should I be worrying about that? So people have been using this phrase called tachycardophobia. I don't like it. Eric Silverari kind of looks like you, but I don't think that is. Now, where does that come from? So there's a scare out there that there are patients out there who, you know, the only thing you're going to find in them is some small abnormality on a vital sign, and that's their trigger. It's a trigger to you that you should be looking at that kid. And that fear comes from actually a fair number of adult studies. They're not kids. When you actually go out and look at the literature, the kids who present with one vital sign abnormality, it happens to be pulse, and they happen to be septic, and that's it, is actually really, really rare. So there's a fright about it. I just want you to know, en masse, it's very uncommon. The tachycardia is your only risk. But we do have to think about it, right? It's something we have to challenge ourselves to understand at a deeper level. And the first thing is that tachycardia, is that really an outlier heart rate when adjusted for fever? What does it mean to be an outlier heart rate? And the second is, okay, it's an outlier, is associated with sepsis or not? Okay. I don't know how many people are in the room, but boy, it's going to be hard to get an answer to this. As a guideline, the heart rate increases by how many beats per minute for each increase in 1 degree Celsius? 5, 10, 15, or depends on age? Go ahead. What's that? 10. You didn't see my slides, did you? So the first thing is, I always thought it depended upon the age. When people have actually looked at this, kind of you look at you just look at the curve itself, there's really not much of a curve. It's kind of a straight line. Right? That's interesting. That's in kids 3 to 12 months, now 1 to 2 years. Kind of a straight line. So I was wrong. I went back to the literature and I said, it doesn't all change all that much. Unfortunately, you guys are smart. So it's about 10 beats per degree Celsius. So it can be up to 15. And of course, then we put in pain and screaming and everything else that we can do in the emergency department, and it goes up. But just fever alone, 10 beats per degree of Celsius. Okay. So that's that association between degree of fever and heart rate. Well, heart rate's up. It's a little bit beyond where you think it should be for fever. Does that mean that there's something that you need to catch? Well, again, it's this needle in the haystack issue. When people have come back to look at patients who were discharged from the emergency department with tachycardia, did they miss anybody? Okay. Tachycardia alone was the reason they had it, they left, did they come back? So this is from, I think it's 2017, 2 pediatric emergency departments, 4 urgent care centers, 126,000 patients in 1 calendar year. It's a lot. They were discharged with tachycardia, which was defined as a final recorded pulse rate of greater than the 99th percentile for age. Oops. Okay. 8.3% of their patients had discharged tachycardia. Think of having to deal with 10,000 kids and trying to make their tachycardia go away before going home. Not possible. So you have to understand that this is going to be a very common thing, that you are likely to see it in 1 out of 10 kids who comes in with tachycardia or so, and it's going to be very common in fever. Doesn't matter. Right? So we said, we worry about tachycardia. How common is it? How commonly is it associated with being your only vital sign for having sepsis? Well, when they looked at these kids, again, 10,000 kids who were discharged with tachycardia, again, at the 99th percentile, think of what the 95th was, they did have an increase in revisits. Small increase in the number of kids who had this discharge with tachycardia came back, more so than kids who didn't. But no CPR revisits, no deaths, admissions were about the same, and no overall difference in clinically important interventions. So again, this tachycardia that we use as a vital sign to say it's the only one that they're going to have to tell us they're septic, it's really tricky. It's going to be a needle in a haystack. Does that mean, however, that we need to ignore it? I'm going to call it, and this is my phrase, believe me, don't use this, tachycardia mindful. So is it normal enough for fever? We discharge a lot of kids from the ER with tachycardia. We think about it. We do think about sepsis. We think about dehydration. We think about myocarditis. And we think about medication-induced, pain-induced. We typically, in a kid like the one we had in that scenario, we will observe them and reevaluate them when their fever is lower. So again, you're going to have to in your institution say, can I do that? Or can I not? You're going to have to pick out that kid whose tachycardia worries you enough that you want to watch them for a period of time. We do that. And if you look at the protocols that are out there now for looking at identifying children with sepsis, these are across different algorithms across states in the state. They all have abnormal pulse beyond temperature correction. Okay, so you have to know how to correct, and then you have to think what pulse is going to be the one I'm going to pull the trigger and either evaluate further, treat the temperature, and treat everything I can to take care of the pulse, and then reevaluate them. We started off with these vitals, as you see here. I had them in a trigger tool. And I will tell you, this drove us crazy. these heart rates were too low. We had to increase them. They actually picked up probably 15% of the kids. We couldn't observe them all. So you're going to have to come up, if you're coming up with a trigger tool, you put heart rate in that trigger tool, you're going to have to come up with something that balances picking up the rare kid with not overcalling everyone. So how do you do this? How do you trigger, how do you get the right kids to say, these are kids I have to worry about? And we always rely on ourselves, and the human is great, and now we have the electronic health record. And the question is one better than the other, or do you need both? So there's been a fair amount of work in looking at how to incorporate vital signs and other aspects you can get out of the electronic health record and incorporate them into these trigger tools. And we're really getting better and better at it. And this is one study that came out very recently, looking at using both vital signs from an electronic health record and that trigger then led to a bedside clinician evaluation to then decide, do we need to do it? Do we need to go on and say this kid is at higher risk? So these guys implemented a 2-stage electronic sepsis alert, vital signs and mental status, and at the positive alert, the physician completes a bedside evaluation. How good was it? Well, overall, 1% of patients met the alert. So if you have 100 patients a day, it's 1 patient. If you have 1,000 patients a day, which I hope you don't, it's a lot. The electronic alert picked up 86 out of 100 who actually had sepsis. Okay, very high specificity. If you actually added in that alert plus the clinician evaluation, it picked up almost everybody. So that's my guess is where we're going. The electronic health record, we probably all know, has all kinds of issues that we all don't love, but there probably is a place for it in triggering, for kids who have potential sepsis, triggering us to go and evaluate them more quickly. So I think over time, we have to find ways of taking the information from the electronic health record, using it to trigger kids who then the doctor will go to and figure out if they really need to have a sepsis pathway to go forward. So that's kind of it for the identification. Okay, tricky. Pick up most, but some of them are a challenge. What about the management? 9-year-old with fever who meets criteria for septic shock. Here's the question. For each hour that antibiotics are not administered, the mortality rate increases. Not at all until after 3 hours. Less than 1%, 1 to 3%, or greater than 3%. Greater than 3, greater than, I have here a smattering of each. Okay. The answer in medicine is usually we don't know the answer. It's always the best answer, but I don't give it to you because I don't want to give it to you. So let's get to the bottom line. Delayed antimicrobial therapy increases mortality and organ dysfunction duration in pediatric sepsis. When I was a resident, and that was 25 years ago, this was talked about, and everybody poo-pooed it and said it was not real, that delaying antimicrobial therapy did not increase the risk of death from sepsis. Little by little, we're figuring out that that's not true. It's just that sepsis is, in general, rare, and death from sepsis, in general, is uncommon these days. So it's hard to find the patients who, if you do something a little bit more quickly, their outcome is improved. Well, as we get to look at larger studies and larger samples, we're figuring out that that's actually not true, that we really need to be thinking about the timing of events. And this is a study out of the ICU. These are kids with more advanced septic shock. And they actually looked at it, and to date, we can't figure out that in the first 3 hours that giving antimicrobials to kids in septic shock improves their mortality. You can see at 3 hours that the mortality actually increases if the antibiotics are delayed. You can see it there. We can't figure it out within 1 hour. Does that mean we shouldn't do it? So the data from pediatrics suggests that longer times to antibiotics for severe sepsis increase mortality. The exact times are unclear. But if you look in adults, I love straight lines. It's never a straight line. I'm sure it's a very crooked line, but I like straight lines. So this is the Surviving Sepsis campaign. It's actually international now. And they've looked at thousands upon thousands of adults And you can see that there's kind of this direct relationship between the survival, mortality, and timing of giving antibiotics. Mortality is 30% in adults over the first 4 hours. There's a 1% increase in mortality per hour if you don't give antibiotics. That's where that data comes from. So this is what we are relying on. We're relying on adult data. It's getting better in kids. We know that sepsis, we can decrease mortality if we give antibiotics early. The timing is not perfectly known, but we certainly see it more in adults. Now if you go into pediatric emergency departments at a lot of places around the States, they have these algorithms. This is what you're going to do at time 1. This is what you're going to do at time 2. This is what you're going to do at time 3. So you've got to identify them fast, and then you've got to have a time frame within which you're going to judge yourself to get these things done. And this is just a piece of one guideline that's used in ER. There's nursing tasks, there's blood pressure support, and then you see at the bottom is antibiotic therapy, and it's within 30 minutes. These are the standards that we're coming in. So you identify them, you have a time frame within which you're going to judge yourself to get these other things done and decrease mortality. This is pretty much hot off the press. Okay, so we've got a time frame. We don't want to get things done in a certain time frame. What about the choices that we make? 4-year-old with fever who meets criteria for septic shock, hypotensive and cool extremities, has a peripheral IV and already received 60 cc's per kilo of fluid in the time frame, let's say within 20 minutes. Pressure choice. Raise your hand for dopamine. Raise your hand for dobutamine. Raise your hand for epinephrine. Raise your hand for norepinephrine. Okay, I love it. That's all over the place. Okay, this is something you should read. So pediatric critical care and a bunch of are they going to cross me off the list? No, let's go. I don't want to do that. Remind me tomorrow. Let's go with remind me tomorrow. Okay. So who's going tomorrow? You're going to be reminded. So these are guidelines that you should read because they go into both emergency care, they go into ICU care. These are going to be your standards for a while. And interestingly, they base their fluid refractory shock recommendations pretty much on one randomized trial that came out a couple of years ago, looking at the comparison of epinephrine and dopamine in septic shock. And lo and behold, there was a difference. Shocking to me. It was surprising to me. Epinephrine came out up front. So from this guideline now, for a kid who if you have a no central IV, you have a peripheral IV, drug of choice is epinephrine. Period. Now, again, this is going to be, you're going to have your cases where you have a child who has underlying cardiac disease. This is for the otherwise typical child in septic shock. If you have a central line and you believe in the theories of cold shock versus warm shock, cold shock is epinephrine, warm shock is norepinephrine. But I urge you, if you're interested, to go back to these guidelines. They were very informative. So let's put it all together. Are we doing okay time-wise? 5 minutes, great. So I gave you the identification, I gave you the management. Okay? Putting it all together is the key. Protocol-based care for children with sepsis is associated with, and this isn't a question, decreased mortality, decreased morbidity, both, or one. Oh, actually, it is a question. Neither decreased mortality or morbidity. I'm going to give it away. It's actually both decreased morbidity and mortality. And actually, if you look at it, at the studies that have been done, the greatest amount of data is in decreased organ dysfunction over the course of the septic shock period. So putting a protocol in place decreases mortality, decreases morbidity. We now have proof of it. And actually, if you're just looking at it, it's a little harder to show those outcomes versus process outcomes of if you put a protocol in place, does it decrease the time of intervention? Absolutely does. Look at the different times here. Protocol used versus protocol not used. Time to first bolus, time to third bolus, amount of fluid given. No matter what you measure, it all looks better when you have a protocol in place. Okay. here's from those those practice guidelines, this is what you need. This is what this is what we're now held to. Each institution should implement a recognition bundle. Okay, that's the one about the trigger tool. Can you diagnose, can you identify those kids? The second is a resuscitation and stabilization bundle to actually put all those things into place we just talked about, like putting epinephrine in versus other pressors. The performance bundle, okay? We've got the identification bundle. We've got the resuscitation and management bundle. Do you actually measure it? Do you see how you're doing? This is what we do. So we have a wonderful person in our division who actually is in charge of quality improvement. And he holds us to the fire for everything. One of the most important things he holds to the fire is, are we getting those pieces I just talked about done in a timely manner? And this is a chart. To the left is before we implemented things. To the right is after. And you can see that the time to antibiotic, this is time to antibiotic, went down. We're meeting our goals. And we're meeting our goals not because we all don't want to meet the goals without a guideline. Have a guideline, we're being held to it. Crucial pieces. And one of the things that I think was really important for us getting there is we do simulation all the time now. Every week in the emergency department on Thursday morning for 2 hours, we're in the emergency department doing simulation. And we simulate these cases. How quickly do we get things done? All those time frames you saw, we hold ourselves to them. And it's done through simulation. So our job is to identify patients, balancing under versus overcalling. I think man with machine is going to be the answer to the question long term. We have to initiate manage in a timely and organized manner. We have to practice, and measure it, and be held to it. And you do have to think about all these things I said, to develop a guideline that's realistic for your setting. It takes time to do all these things. But if you think about the tasks and the time frames, and you simulate, you will get there. And if you want more information on this, I certainly can provide what we do. There also is a large collaborative in the States now called the American Academy of Pediatric Sepsis Collaborative. If you look that up online, you will get all the information you need. And it's about 50 plus hospitals now who are basically looking at each other and saying, how are you doing with taking care of sepsis in these young children? And I think it will help your care overall. Thank you. Questions? Or I'm doing no time for questions. Done? Keep going. Do I have time for questions? At the end.
Thank you, Dr. Diane. That was an excellent lecture. Next, we invite up one of our fearless leaders, Dr. Suleiman. So he is the chairman of today's scientific committee, and he is also a consultant at he's a pediatric cardiology consultant and co-director of Kids Heart Medical Center here in Abu Dhabi, as well as Dubai and Bahrain. He is also assistant professor of pediatrics at Columbia University in New York, in the United States. He earned his Bachelor of Medicine and Surgery at Damascus University in Syria, and he then went on to study pediatric cardiology in the United States, earning his American Board of Pediatrics as well as his subspecialty board in pediatric cardiology. He is additionally a fellow of the American College of Cardiology. And circling back, he did his fellowship at the University of Illinois Chicago. I welcome Dr. Suleiman.
Thank you very much. Thank you for all the attendees who made this conference a special one for us. Thank you to all my partners who support our work and making this conference happen. Thank you to Dr. Hamdan, who always never stop working. Thank you to our colleague in Columbia University, and thank you also to NMC, who also support this conference. And special thanks to my wife and Dr. Hamdan's wife, who really the true drive behind this conference. Well, many of you know the way it's very hard to be a speaker after Dr. Dayan. He's a high caliber speaker that made me feel I'm not sure if I want to do this lecture, but I'm going to keep going. So our disclosure, I have nothing to disclose. We're going to talk mainly about congenital heart disease, everyday challenge, at least for pediatric cardiologists. We'll talk about pulse oximetry role, pattern of recognition for congenital heart disease and clinical scenarios. And then we will finish, if we have time, about exercise activity restriction. This can't see any light, right? All right, so the first thing we're going to talk about prenatal circulation. It's very interesting, and we always talk about it. The thing that we need to remember, there is always a way to go. Even if you have a serious problem in the heart, there's always a way to go around it. So to mix the four chambers together and make them access each other, you have the PFO, and then to mix the ventricle together, then you have the PDA. So these two ways that make it very much possible for the heart, even if you are losing one of the ventricles, you are having only one artery coming out of the heart. So this is very much that way that children before birth, they have no problem whatsoever, and nobody knows about them. The other very important thing that we need to remember, that usually the saturation before birth is about 70%, or even 60%, and that's the oxygenated blood. So that's a very, very desaturated for after birth. That's why those children after birth, they are still used to the saturation in the 60s or in the 70s, even if they have significant congenital heart disease, unless one of these major issues, which is the PDA or the PFO, you have a serious problem in them. So you have a time until the disaster. So just looking at the heart oxygenation and the pressure, here we have the right atrium, right ventricle, and the other side left atrium and left ventricle. As you can see, the pressure in the right side is low, which is 25/8 in the ventricle. In the other side, it's usually systemic. And the saturation definitely reflects also between the right side and the left side. So on the right side, you have the saturation in the 70s, while in the left side, you have the saturation in the 100. So this is the bottom line, how the heart from the pressure point of view and from the saturation point of view. Now, I'm gonna talk a little bit about the pulse oximetry. Many of you know that it's almost universal right now to use pulse oximetry. We have a different way, especially for newborn, that's when we have serious problem about them. So different way to look at it. We usually measure the saturation, a mandatory measurement of saturation 24 hours after after birth. And according to that, we'll decide if the child needs something or not. How many people use the saturation in their hospital as a standard? So it's good news. It seems like many people raise their hand. Hopefully the others, they're just not working inside NICU or something like that. So this is the chart that we are utilizing, and it's a way of Dr. Dayan looking at sepsis. This is the way that we're looking at congenital heart disease. So this is a chart that developed by American Academy of Pediatrics through many years until we conclude this is the way we should approach congenital heart disease to be detected in the first 24 hours. So as you see here, the red line, the yellow line, and the green line. So after 24 hours, you will have to measure at least in one of the, or two of the upper extremities and in one of the legs. The legs, one is okay because you only have one single artery going to your legs, which is the descending aorta and then branch. So the saturation is supposed to be the same in both legs. If you are getting a different saturation in the legs, you should question your machines and say, what's going on here? Why am I not getting the same number? So when you look here in the green side, if you measure the saturation after 24 hours and it's more than 94%, or the difference between upper and lower, not more than 3%, then you are probably safe and you are doing just fine. So no problem, you can discharge this patient, send him home. On the other hand, in the red line, you have less than 90. So if you get less than 90, it's case closed. You call your friend cardiologist and start your working process. Now what is in between is the most important thing, which is between 90 to 94, how you handle it. So if there is an extra more than 3% different, or it's between 90 and 94, then you have to repeat the screen within 1 hour, and subsequently you decide if it go above the 95, then you are fine, you can send the patient home. If it's less than 95, then you go to the other side. And again, the same thing, if you have 90 to 94, and the difference is more than 3%, you can also repeat in another 1 hour, and subsequently you decide that this patient will need more screening and more cardiac evaluation. I'll just say that you need to keep in mind that congenital heart disease patients, they don't talk, they don't know how to look like after birth, they're just starting learning their skills from that moment. So we have to be vigilant about them to be able to detect them early. So this is a very, very important chart for us. It doesn't save every single child because there is obstructive congenital heart disease like severe pulmonary stenosis or severe aortic stenosis, and those maybe you're not going to detect them easily by the saturation. Anybody know what we are measuring when we do saturation? What we are measuring? Measuring the blood where? The oxygen where? Where? In the red blood cells. So measuring the oxygen in the red blood cells, and sometimes even if you have less flow, but the saturation is still 100%, that you will still get a saturation of 100%, and that will mislead you, and that will, when you miss some of the patient. So, all right, I'm going to ask a few questions, especially for the last one in the back. I'm going to ask him to answer the first question. All right, so you did your saturation, and that's, I owe this slide for Dr. Hamdan, who helped me to organize it. So you have a saturation in the upper extremities, 99, 97, and the lower extremities, 99 and 97. So what do you think about this patient? Normal? Normal, yeah? Send him home? By the way, I want to give you a very clear message. When you say the numbers is normal, you have also always to think the child is normal. So this number is normal. If the nurse told me the patient doesn't look right to me, that's more important than these numbers that we are talking about right now. So keep in mind that if this is normal, then you need to say what's normal. However, saying normal, this patient could be easily hypoplastic left heart syndrome and having high saturation. And if we get a chance, we'll talk why this patient will have high saturation, if until he has no left ventricle whatsoever. All right, the next one, saturation in the upper extremities is 80 and the lower extremities is 95. Any volunteer? Any volunteer? Should we send him home? Send him home, yeah. Let him enjoy his life. So any diagnosis suggestive? What do we do? Start prostaglandin? No? Alright, so this guy, his head is not happy. His legs very, very happy and very excited. There is too much oxygen down there. But there is nothing in the brain. Okay? So this could be only with transposition of great arteries. So if you have a saturation, your legs is higher and your brain is lower, that's a transpose because your head becoming your legs. No, that's not true. Alright, so this is a very, I want you to remember the number B. So you can make easily the diagnosis without even calling the pediatric cardiologist, and you will amaze me when you say, you know what, I have a patient transposition of great arteries. I'll ask you, do you have echoes? No, but I know. Why? Because I did this. So if you tell me this information, I will really buy it from you, I'll be proud of you. So the next one, what about this one here? Now the head is better, feeling good. The legs are very sad. So the legs still living in prenatal, and the head already in the postnatal. So what could this patient be? What? Coarctation? Okay. So coarctation is the right answer, assuming that you still have a PDA open. In those scenarios, I'm assuming the PDA is still open. Sometimes when it closes, things will change. So what else from the neonatology point of view that will give me exactly the same thing, but there is no coarctation? Well, it's very, very common. Huh? Pulmonary hypertension. Dr. Yasin, Dr. Hakam Yasin is our pediatric neonatologist, and he's not supposed to answer. But he's cheating to you guys, so thank you. So that's pulmonary hypertension. But again, keep thinking about congenital heart disease. This could be a coarctation. Okay, next one. Heavy in his legs? No. Heavy in his head? No. So what could it be? Any idea? And he still has a PDA just for the sake of the talk. Could be anything. We don't know. Could be anything. Could be just he has a sepsis and his perfusion is not adequate. Could he have a congenital heart disease? Could be a hypoplastic left heart? Could be anything. So when you have something outside the range, you think about the most common, especially for a newborn baby, which we will talk about a little bit later. But in general, we think about congenital heart disease as a very important thing. Okay. Oh, by the way, I forgot to mention, the heart has a very nice neighbor. We call it the lung. So don't think about one without thinking about the other. So when you think about the heart, say, where are you? Where is your address? You say, I'm close to the lung. So that's mean I'm going to think about the lung also. All right? But when you talk to a cardiologist, just tell me about the heart. All right, we'll get out of this challenging things. We're going to look at kind of pattern recognition that we see in every day. And I'm going to talk a little bit about very common case, and it's not in a newborn. No, this is in a newborn. Okay. This is my favorite, and this is the second time I show you this case because it will happen to you. You know, most of you know that I like WhatsApp, so I work on it, and my wife, if she will leave me one day, that will be the reason. So this is a message that I received from Giwin, and I don't know if Doctor is here, the one who's. So she said, I need urgent consultation. Okay, yes, go ahead. Okay, 4-month-old presented with signs of URTI since 1 week. So he was fine before that. No fever, 3 days back, become more sick with cough and more feeding and shortness of breath. Okay, she sent me this. Okay, clinically tachycardic and hepatomegaly, no gallop, but has crepitation, and she gave a Lasix assuming there is something wrong with the heart. So, because they have an adult cardiologist in the same place, she, decided to use that adult cardiologist. He did an EKG for this patient. Okay, and this is real life scenario. It's not I invented it. This is a true real scenario. And our adult cardiologist, he said this patient has dilated cardiomyopathy and he has normal coronaries. He did the echo by himself. So what do? Do you believe that? You buy it? You don't want to buy it. Who want to buy this dog? Of course you're not going to buy it, because if I sell it to you, I'm not going to buy it here. But what I'm trying to say is that be very careful on things that could have the patient in a very serious issues, that make it sure to go to the max to figure out what's the patient has. So anybody know what this patient has? What? Who? How did you figure that out? So you diagnosed it just from this. And you are not a cardiologist, thanks God. Okay, so what made you think about that?
Diffuse.
Dr. Eric Silver is our electrophysiologist from huh? He's our electrophysiologist, and we are privileged to have him here. So can you comment, Dr. Silver?
Yeah, there's Q waves and we want an ABL.
Okay, an ABL. And this is and one and an ABL, right? Okay. And where else? Okay, so this is basically, you can figure out this kind of problems without doing a lot of work. So this is a very important. It will happen to you only maybe once, maybe twice. I have seen many because I'm working in pediatric cardiology. And to be honest with you, in 1 week, I saw 2 patients, one in NMC in Dubai and one in normal Kiwin, and both of them were diagnosed from the EKG. So again, this is just a picture. Unfortunately, it's not like picture. That's the echo, and this is the how's the aorta here. As you see it was written, and the pulmonary artery, and then there is a connected left coronary artery. So what's this? What's going on? Why this patient didn't present after birth? Because the lung pressure usually high, and allow the blood to go to the heart and perfuse the heart. With time, the lung pressure go down, and then the blood go from the right coronary artery in one single circle, going back to the lung. So you are stealing from the right, you don't have a left, and you are stealing from the right. So this patient basically, at death, this diagnosis is almost always a death sentence with exception of 5 or 10%. So this is a very serious, so if you want to have in your resume, one of the patients with ACABA died, well, you know, you see who's going to hire you. That will be a very good thing. Okay, we're going to move a little bit older child, 16 years, 15 years old. She come with cough and shortness of breath. And we did an X-ray. Any suggestive, what kind of pneumonia does she have? Pneumonia? You don't believe I'm going to present a pneumonia case. You're being very smart. So there is overcirculation in the lung, and mainly you see here, and I've seen this is a true patient. This patient was diagnosed with right middle lobe pneumonia and was treated and so on, and the patient didn't get better and so on until we got back to the cardiologist. So this is the case of the patient. So I'm just going to make it easy. I will say you suspected ASD, which patient at this age most likely have something not so critical. But I will say you suspected an ASD. So I want you to tell me what you should expect from the physical exam for this patient with suspected ASD. Number 1, normal is 1, variable split is 2, and band systolic murmur. Number 2 is 1, fixed split is 2, systolic ejection murmur, right upper sternum border, and so on. And normal is 1, fixed split is 2, and the right, then normal is, you can read the rest of them. Or normal is 1, single, and loud is 2. Which one you think is the right answer? So this patient for sure will have a murmur, assuming you have the right ear that day and the right stethoscope. So we all carry the stethoscope with us, but trust me, not many of us know how to use it. And when we fail the patient, we don't fail them because we don't have the MRI or the ECT or the high-tech, big, huge hospital. We fail because we don't use the basic, and that basic is a kind of a stethoscope. And so when you hear this patient, you will hear a murmur. Now you have to concentrate on the second heart sound, and you should have the split, the fixed split of the second heart sound, due to always increase blood. And you will only learn the split of the second heart sound if you always use again and again and again and again, and you say, this patient, I didn't hear it, I'm going to hear it, the next one, and so on. Otherwise, you will say, this is another murmur of everyday murmur, so let them go home. So if you're not sure, and you don't want to trouble yourself, especially in a country like our country here where there's many expats who may have only one single chance to see you, then you have to make sure that you either have a clear diagnosis or refer this patient to appropriate care. So this is the EKG, and as you see, there is the PR interval is prolonged, and there is right bundle branch block. And this is Dr. Hamdan. He decided to close the ACD through the cath. I was doing the echo for him, but you didn't see me. So this is the device here in the other side, and here is the echo. We'll show you the second atrial septal defect. This patient went home in the next day, no problem, no surgery, nothing. So it was a good work. Okay, I like this one, and he's always big, he's always blue, and he's always boy. Kind of something interested. I don't know if does he look blue? Do you think he's a boy? I don't know. So this is something you need to remember when you have a big blue boy that you have to think about this. And this is a true patient from old time from Tawam Hospital. And I just passed by the NICU, and this baby is there, and I looked in here. Oh, by the way, please, when you suspect congenital heart disease or something wrong with the child, always check the SAT upper and upper. And how many times? And we keep saying the same message over and over, but the doctors don't want to listen. So always check upper and lower, and then you will figure out. This patient has been with the intensive care unit, having this saturation, and nobody, we have the machine there. It's just for the show. Nobody wants to read what is wrong with this machine. Why the saturation here is different than this one? So as you see, so anybody suggest what do you think about the EKG lead? Do you look good? Look great, yeah? Okay, so when you pass, make it a habit. When you pass by the PICU or by NICU or by even a normal child in the ER or Dr. Dayan and so on, just make that screen make sense to you. Does it make sense to me? This is where I'm going to save the patient. It's not anything else. So if it's, now we put it in electronic. That's fine. But this is even more immediate action while you are walking all the time. So look at the EKG. If you see it like this, say, hey nurse, what's going on? Why this is going like this? And then the second one, you have the saturation in one side and the saturation in the other side. Which one do you, okay. Do you think this is, what could be the diagnosis for this patient? What is the saturation here in the 67, and then there is 99. This is a true. I mean, I'm not making it up. Trust me. Okay, so what do you think this patient has? His legs happy? You remember? Transposition of great arteries. So this patient, you just picked him up, make it sure also, I'm just going to show this. Okay, make it sure when you look at the monitor, so you have a good wave. So if you don't see a good wave, don't say the saturation of the patient is 99. It's not 99. You don't have a saturation. You don't have a number. So make it sure that sometimes I have seen when some of our nurses, like, they hold the probe, and then you don't know which one you are measuring, the patient or you. So who's the deciding, you or the patient? So make it sure that you validate appropriately and you get a good wave out of it. Okay? So this patient has a transposition of great arteries. I'm not going to go through the rest of the differential diagnosis, but this is some of the famous T's that you can always remember whenever you have a congenital heart disease and SNIT. By the way, does anybody know why this patient is big? Why he's big? Min Allah subhanahu wa ta'ala? Because his mom is diabetic. Okay, so so in this patient, her mom has a diabetic, that will increase his risk by 5%. It's not only for diabetic mom, but if you have a diabetic mom, always think about transposition of great arteries. And he's blue because this is the most common congenital heart disease with cyanosis that you can detect at birth, immediately. Because you cannot have his brain get high saturation. There is no way. Okay? Because his artery, aorta, coming from the right side. So there is no way for me to get to the brain and fully saturated blood. And why he's boy? Because he's a boy no. Alright. So there is more risk for transposition. If you have transposition, usually most of the time they are both. Alright, so now you decide to start the prostaglandin for this patient, which is a good idea, and other management, whatever you want to do, and you decide the patient saturation right now is 50. Okay? So what do you do for this patient? Now, urgent surgery, urgent intubation, or call the cardiologist. Which one is more important to you? Call the cardiologist. Make me happy. All right. Definitely, I want you to call the cardiologist because you already we assume that you already have a diagnosis from before. So why do you think this patient is saying, there is nothing wrong with him other than the heart? Why do you think his saturation is going down? Do you know what is the saturation, the 50? Where is it at? Which arm? Which leg? Leg or arm? Hopefully the arm. Okay. So hopefully the leg's still happy. Okay. So what's the reason why he's going down in the saturation even though it's not the prostaglandin? It's the saving method. Let me go back to the physiology of transposition of great arteries to tell you. Now, do you know which one is the right ventricle there, the left ventricle is there? Which one has high pressure, the right or the left? The right, because you are facing the system. So if you have a PDA, you can see it there, a PDA, the blood from the aorta will go up, and where is it going to go? Is it going to go from the pulmonary to the aorta or from the aorta to the pulmonary? So the aorta to the pulmonary, so that desaturated blood. So the PDA may not help you very well. because you are sending more desaturated blood to the lung. So I need to send more saturated blood to the body. That will bring us to the concept of shunting and mixing. Mixing is good. So when you mix everything together and you become wife and husband, everything is good, fine. Then that we'll talk how we're going to become mixing. And or shunting, this PDA only shunting, so it's not going to save the day. It's just a lot from one side. The other side doesn't care about you. So what we do, we call the cardiologist who's going to do a rush kit for this patient, which is basically opening the atrial septal defect, and it could be done a bedside and so on. So that will allow the mixing in the both atriums, and then when you mix in the atriums, they will go to the ventricle and everything will be fine. So your saturation after that will go probably to 70s or 80s, but the thing will be very much mixing and it will be balanced. Can you stop prostaglandin after that if you have a large ASD? Can you stop it? Because there is side effect. Anybody know what's the side effect of prostaglandin? Huh? Apnea. So this is the scary part. So you're thinking you're safe in the patient, but I'm keeping your PDA, but I'm going to stop you from breathing. So we're going to be in a good shape that way. So no, keep in mind that when you put a prostaglandin, the patient may go hypotensive, may go apneic, may have seizure, and so on, some other problem. So in this situation, if you decide to take the prostaglandin, and usually the cardiologist will help you, don't take it all at the sudden, because you might get a rebound pulmonary hypertension from this patient, and then you get some serious trouble. And we have seen that in previous. Okay. This is another true real patient. This is in Al-Ain, in one of the great hospitals, and probably the pediatrician who were taking this care of this patient is here. So this is a 2 days old baby, normal spontaneous delivery, 3.8, no complication, everything is okay. Very good. 24 hours passing by, very good. So when somebody starts with you good after birth, that means he's still living in his past. He's still living inside his mom's womb. So he did not see the reality of the life. Okay? So in the beginning he was just fine, and suddenly after 24 hours things start changing. In the little subtle things that you need really to keep your eyes very much open to realize what's wrong with this patient. So he, yeah, 2 minutes? Anyway, so this patient basically ended up having more problem than what we think. That's not him. This is his X-ray. I'm just gonna go more. So initially the patient just started to show a little bit desaturation, a little bit of increase of breathing. They called the doctor. The doctor said, I'm busy in the ER, I cannot come right now. True story. I cannot come right now. And then, okay, everybody slept on the issue for another 3 or 4 hours, something like that, and they start to look on the issue. So when the doctor finished his WhatsApp and his ER, then he came back. So after 4 hours of waiting with this patient breathing fast, now we are coming back. What do you think? His respiratory rate is still okay? Is he comfortable? Do you think his liver will be big? Or he will have warm extremities or not? And if he's still alive to start with. So this is a very serious issue. When somebody calls you for a newborn, specifically a newborn, please keep in mind, I have to attend this. You know, nurses, if you train them right, they will be your best help to save these children. So this patient was basically coded, and he was resuscitated, and he ended up by being a significant congenital heart disease. He was admitted to NICU, blood gas was done, and so on and so on. And this is basically what we talk about, hypoplastic left heart. The left side is very, very small. The right side is normal or more than just normal. And basically, before birth, you are depending on your PDA and your ASD, assuming everything is okay. So after birth, the PDA either will close or the ASD will be small. This is the sidewalk that you can use to drive your car if there is a lot of work. So if you don't have a PDA, don't have an ASD, you are in a very serious trouble, and probably you will need to look at what's going on. This is a very nice picture. I think you should all know it. When you do an X-ray and you still didn't think about the other lung issues, and it has the biggest ever X-ray for the heart shadow, that's a Epstein anomaly and Telbrook and other ways. This is the total anomalous. I'm going to keep going. I will just say one message that there is a few things in the presentation about it for who do we stop from exercising, which patient we tell them not to exercise. And this patient, basically, you have to keep in mind, we allow everyone to exercise with a very, very few limitation for who we are gonna limit the exercise. And this is the one that we need to remember here. So coarctation, especially if there is high blood pressure, you need to treat the hypertension initially until you guys say it's okay. Or basically, patient with Marfan syndrome, this patient, he can exercise, he can go and swim, he can do things, but you don't want to get them hit and then cause them to have rupture or cause them to have pneumothorax and so on. Cardiomyopathy because they have arrhythmia. And then finally, patient who is using warfarin because of the risk of the bleed. So you have to tailor your activity according to what you are doing for the patient. But the general rule, don't restrict anyone. I get a lot of, he has an ESD, was fixed whatever, how many years ago, and I am not letting him exercise, doctor, I'm doing a good job. No, you're not. So talk to your doctor. The message from you is to let everybody exercise, and especially children. To be honest with you, in the real life, you cannot even stop them from exercising, but you can stop them from doing a specific activity like running in a gym or doing some soccer and stuff like that. So don't risk your kids. And if you do, then send them to proper evaluation and let the cardiologist clear them rather than you decide. So the last slide. Okay. So you can do anything. So low saturation newborn is a very important thing, especially if there is no respiratory distress. This is a big red flag. If you don't know which congenital heart disease, no problem. Just start prostaglandin. You're going to be a cardiologist if you do that. And then you will figure what's going on later. Let kids be kids and allow them to play. And when things seem odd, just call your friend, pediatric cardiologist, but not adult cardiologist. And he will save the day for you. Please remember that next conference is going to be in Al-Ain, so hopefully we'll see you all there. We have 2 conferences for next year, one in Al-Ain and one in Al-Ain. Thank you very much.
Good morning. To start, does anybody have a question? Yes, sir.
Dr. Surya from National Hospital. Thank all speakers. My question and Dr. Dayan. First, appreciate that what we can do for prevention from sepsis in pediatric, that we have more awareness and we have to have time frame steps and the simulation. I appreciate that you have in your department. But my question was about using views in the pediatric emergency department while the patient waiting for the admission, sometimes waiting there many hours, because we have a lot of obstacles using views in the emergency department. Pediatric early warning signs.
Early warning signs. So your question is whether to use them?
Yes, what's your opinion about it? Because we have a lot of challenges in the pediatric emergency department to use it. What if you advise or not advise?
So you know the signs that I talked about, which early warning signs to use?
Use in emergency department.
Sure. So I think I'm understanding the question right. This is again about the identification side of it, the trigger tools.
Yes.
So the trigger tool, and again, I'm happy to share this with you. We actually have that specific trigger tool we use is that combination of that risk assessment of the high-low risk, and then we actually do use that vital sign risk, if that's what you're asking. I'm not sure that's what you're asking.
No, this is okay. I agree with the person to start later. For a patient who waiting for a few hours, 6 hours, 8 hours, 10 hours per admission, if use applicable or not? What's your opinion?
You are actually saying so the ongoing evaluation over time. Yeah, that's actually very tricky. So in terms of the trigger tools, the early warning signs, we actually continue our sepsis tool, especially the vital signs, throughout the visit. So that trigger tool will actually alert us again and again and again. I will tell you, if the question is whether that's annoying, it is quite annoying. There are those rare patients, and actually you will pick them up every once in a while, who that trigger tool will go off for them over the course of the evaluation in the ER, and you will pick them up. So I don't love them. They do annoy me, but you will every once in a while pick up a child by having those continued evaluations over time.
Excuse me. Can everybody please be quiet for our questions? Additionally, we will like you to stay in the auditorium because you'll need your code to get your CME credit. So if you could please be respectful to the speakers, we'd appreciate it. Thank you.
My question to Dr. Khalid. Thank you very much for your presentation, but for the first case you presented with right-sided diaphragmatic hernia. On the X-ray, it was not suggested at all of the right-sided diaphragmatic hernia. So, on which basis you provide diagnosis? Probably ultrasound was done to check for effusion and it was accidentally discovered. Now, did the baby require some further investigation or contrast to confirm diagnosis, on which basis the pediatric surgeon did the surgery? Number two, I don't know if you did answer for me, what was the finding and how it was repaired? Laparoscopically or laparoscopically?
I mean, thank you very much, a great question actually. Well, this is the thing, that the association of a group B sepsis and not able to meet the oxygen, or the need for more support, with the deterioration of the X-ray, this is actually triggering to do more investigation, in particular the ultrasound. The ultrasound confirmed the diaphragmatic hernia, right-sided. There's no more actually investigation done to prove it, and the surgeon was happy to go and successfully repair the hernia. So the ultrasound is enough to confirm. And actually, you can actually do also isotope study, but per se, the ultrasound is enough to confirm the diagnosis of a congenital hernia. And the second question, sorry.
So probably this is a surgical question.
Yeah, surgical.
How it was repaired and what was the finding? It was really a diaphragmatic hernia, or it was a depression of the surgery?
No,
or is it a orgasm? Because we don't have a clear picture what was the defect and where was the defect.
Maybe I should provide more slide, but actually it's confirmed to be diaphragmatic hernia, congenital diaphragmatic on the right side, and it was repaired successfully, and the baby has 100% recovery.
Thank you.
Good morning, and great thanks to all the speakers. Very good session. My question is to Dr. Suleiman. Oxygen saturation monitor pre and post-rectal is being used as screening tool, certainly from the Trust Hospital I'm coming from UK. But we do it in the first 6 to 8 hours, and we found that not only is useful really to find cardiac cases or PPHN, few cases just been presented with a poor saturation all over and found out to be neonatal sepsis. And my question is, why after 24 hours? Why not in the first few hours of life?
Thank you for the nice question. Now, if you want to start screening early, you will have a lot of false positives, a lot, too far beyond what you can handle. And everybody, if you will end up by having these patients, bringing them to pediatric cardiology evaluation, I'm going to have the best income in the whole country. So the point is, we try to eliminate the factors that after the transition of the congenital, after birth, the initial transition, we'll try to eliminate it. But again, if you have other signs, this is just a toll for congenital heart disease, and this is not for intensive care. Please remember, this is not for intensive care patient. This doesn't apply. It's not for patient who has high respiratory. I'm talking about patient who's in normal nursing. They have no problem whatsoever. They don't breathe fast, they didn't do anything, they're just a normal kids. This is what this saturation was meant for. So if you have other patients who think there is some early things, they breathe fast, you need to start doing your work here. And for sure, you will pick up this patient.
Well, when we get it abnormal in the first 6 to 8 hours, or it's a borderline, we tend to repeat it. I mean, I understand, but there are obviously parents who are desperate to go home, and it just could be catched early if there is any problem. But I understand your explanation. Can I ask another question to Dr. Khalil? Your case was very interesting. Babies who tend to have the Coxsackie B or intravirus infection, they tend initially to present with some sort of encephalitis, and then the myocarditis tend to follow after that. Were there any sign to indicate, apart from apneas, because they do get brainstem involvement as well, so one of the signs, was there any clinical sign to indicate that there was some sort of encephalitis, like the baby being quite sleepy, not really waking up, quite withdrawn, just at least retrospectively?
Ma'am,
I'll answer.
Oh, he has time.
You can answer.
Yeah, sorry, thank you very much. Just we thank all the speakers. I think you agree with me that this was a very fruitful session with 3 excellent speakers. And we would like to do just a small token of appreciation. Dr. Peter Diane. Thank you very much. And Dr. Mohammed Suleiman. Thank you very much.
Thank you very much. Just going to give you the code and you're free to go. And then you will be seated on the screen. So the code for this session, Lily. Sorry, but I have to cut short a moment to your coffee break because you know we're over time and many of you have engagement. So we try to stick time as much as possible. So this is the code. It's MH05. So just put this.
Yeah, I would.
Put this in the area in the evaluation sheet that you have. It's MH0518. Okay, so we'll come back at 10:45 sharp. Please be back by 10:45 sharp for session 2. Thank you.